Hi everyone, welcome back to the Chatty Vets podcast. I'm Brendan.
And I'm Charlotte. Thank you for tuning in. We're back again with our next bonus episode. We hope you enjoyed our last 2-week takedown last week, and thank you again to our lovely guests that we had joining us.
Yes, thank you. Today we're changing it up, going back to one of our clinical deep dive episodes. We are going to delve into our endocrinopathy series, talking today about all things hyperadrenocorticism, i.e. Cushing's disease.
Just before we get started, we wanted to mention something really exciting that's coming up. So just in case you've not seen on our socials, we're actually about to start running our first CPD event, which is very exciting. So on Tuesday, the 21st of July, we're going to run our first online CPD event.
Yeah, so if you're a new graduate vet or a final year vet student and are feeling a bit apprehensive about diving into practice, we've got you covered.
Yeah, join us for our new grad consult survival day, where we'll be covering the common consultations you'll see in small animal practice and how to approach them, how to deal with tricky clients, and generally how to ace being a GP vet. You've got all the skills. We just want to help you feel a little bit more confident before you take that leap into GP practice.
So if you're interested, head to our social media for more info or go onto our website at chattyvets.com. We hope to see some of you there.
And also remember, Brendan has been amazing and created CPD certificates that you can access on our website.
Yes, I have actually been amazing. I was really proud of myself.
It took him ages, so please use them.
It did. It's a whole weekend.
Yeah.
If you click on, you answer a few multiple choice questions. You can have as many tries as you like. And there's only like 3 or 4. And then if you answer them correctly, it will literally email you a CPD certificate for that podcast episode that you watched. So you get 1 hour of CPD. And obviously, if you've listened to loads of episodes, you can get yourself a few of your CPD certificates.
Yeah, because like we said before, each podcast is actually CPD. So make sure you are claiming it and using the certificates as your evidence. So yeah, click on. It will make Brendan very happy. Anyway, back to today's pod. So when we were planning these episodes, we had a bit of a chat, didn't we, Brendan? Because for Addison's and the Addisonian crisis, for DKAs, we thought there was so much to chat about. We'll be like, we'll easily fit an hour's podcast discussing it. But when we got to Cushing's, we were like, is there really enough to say? You see it's Cushionoid and you give it some meds. But I think we've both been really surprised about how much there is about Cushing's that we actually maybe didn't know beforehand.
Right. I'm going to say, if you listened to the thyroid episode and thought you're going to get something similar with Cushing's, you are absolutely not going to. This is so different. What I realized, everyone vaguely thinks they know Cushing's, but I think there's so many things that I learned writing this about why things happen that I think this is a phenomenal subject to get into. Suddenly, you'll understand so much more about steroids in general practice and why steroids have side effects they do have, how we treat low blood pressure, and so many other little funny aspects of that you never really realised you didn't understand. Even DKA and the origins of that will kind of cover a lot of this within Cushing's, because believe it or not, they're all connected with cortisol.
Yeah. And I think we will be recapping some of the basics today. So to talk about, exactly what is Cushing's disease and what meds do we use and how do we manage it, etc. Obviously, we're going to speak about that. But I think we're going to go through it from more of a pathophysiology background, which sounds really dull, but we promise you we'll keep it interesting. But I do have to admit, working a bit more in out of hours now than GP practice, this is definitely more Brendan's forte. So I will be asking you lots of questions as we go along, and I'll be as in the dark as anybody listening probably. So, but we'll try and get through it together, and hopefully we'll give you some really cool clinical nuggets that you can use in your day-to-day cases.
No, it absolutely. You know what? It's gonna affect everyone, and even emergency, because all the immunomodulation, the stress leukograms, and there's so much there. So I think it's a real goodie, and this is a proper deep dive, but I think it's really clinically relevant. So so let's get into it, yeah?
Yeah, go for it.
Let's start off with a quick reminder about what Cushing's disease is. Essentially, it is the body producing loads of cortisol all the time, whether that's because of a little pituitary tumour or an adrenal tumour. And we'll get into this a little bit down the line. And all that steroid in the body has a multitude of effects. And now we know them. So, pot belly, loss of muscle, panting, the immune system that's altered, hair loss, all these things. So we all know the Cushingoid dog. Typically, it's going to be that small, curly-coated kind of little white Bichon Frise or, Border Terrier or one of these typically. So, but what I wanted to do was talk about how does this actually happen? How does all this cortisol have all these what seem like diverse effects? So, and then once you understand that, you'll remember much more better all the kind of facets of Cushing's, and you'll be able to diagnose them and manage them much better too. So if you're looking at a Cushing's dog, I find often the client's going to come not well. They might come because of the hair loss. Obviously, usually it's symmetrical. You can kind of slightly irritate the client by. I find by where the alopecia is, you can just pull the hair out around the alopecia and make it even bigger, and it just kind of falls out in your hand. I do that. So yeah, and obviously weight gain, and the owner's battling away, reducing the food, but the weight keeps going up. The dermatological signs, the hair loss, I think, is a bit more later onset.
I always remember being taught at uni there was 4 Ps, I think it was. So you've got polyuria, polydipsia, polyphagia, and potbelly. That's what I remember. So if you remember the 4 Ps, then you can't really go too far wrong.
5 Ps, panting.
Panting, yeah. Maybe it was
panting,
5 Ps and I've just forgotten one.
Pooing. I don't know, I'm just making it up. Okay.
So basically, if you see any of them in a consult room, then Cushing's is definitely on my list. So yeah.
And the most really important thing, they're well. That's so important. They're not unwell. Because if they're unwell, it's going to really mess up your diagnostics, and we'll come to that later. But these are well dogs. They're drinking a lot, and that's really important that you don't just, I think I've touched on this before. You don't just go, are they drinking a lot? You're finding out, do they now need a wee in the middle of the night? Are they now weeing in the house when they never used to? So are you suddenly finding you have refilling the water bowl unexpectedly? So these, you need to ask it in different ways to get that information out of the client.
Yeah, definitely. Yeah. Okay. So I think we also know how these dogs are going to present, and we all might have a suspicion they're Cushingoid, but do we actually understand why they present like that sometimes? And cortisol is definitely the thing that we need to dive into a little bit more here. And we think of it as a survival hormone, but you wanted to dive into this a little bit more, Brendan, didn't you? Because it's so interesting.
It's unbelievably central to everything, and it's relevant to so many different conditions. So yes, basically adrenaline is survival hormone number 1. Yeah. Immediate danger. Everyone knows this, don't they? Your blood pressure's up, your heart rate's faster. That's adrenaline.
Your fight or flight.
Fight or flight. But why we're all taught that? Because that's actually not as helpful. What's so important is cortisol's role. So cortisol is mostly there to ensure the brain has a good supply of glucose. Now, from that, so many things spring out. And there's so many adaptations, because cortisol is also there for if you're starving, if you're bleeding, if you had loads of trauma, and all of cortisol's effects will help you. We'll go through these one by one. And I don't know, I think a good place to start is, you mentioned, Charlotte, one of the P's, polyphagia, eating lots. Now, that is a really easy one to explain, because I don't know if you've ever asked yourself, why do steroids make you eat?
No. And to be honest, whenever I've explained to myself why Cushingoid dogs are hungry, it's because I'm like, oh, they've got high levels of steroid. And that's where that's where it's left.
Yeah. But if you think in an emergency, you want to maximize your glucose to your brain, you've got to eat lots. And that's the easiest way. So essentially, cortisol makes you eat well to get the glucose in. Let's feed your brain. So I know it sounds like ridiculous, but this is how, as we go through these, you'll see. Now, look, step number 2 is, if you look, oftentimes in starvation or whatever, your cortisol's firing off, there is no food to eat. So plan B. Plan B is the other thing that cortisol does so cleverly. It's going to go, well, you can't eat, you're going to eat yourself. And that's when you start.
Cortisol is a cannibal.
It's a cannibal. No, you're going to break down your muscle. So Cushing's myopathy, you break down your muscle into amino acids. They travel to the liver. Your liver turns them to glucose. In that, I know, don't turn off gluconeogenesis is the word we use, but basically you're getting protein, you're making sugar. And this gives you the second sign that we were talking about, loss of muscle. And the other thing we do is we break down our fat, but that's a little bit more nuanced, because we all know that steroids and Cushing's disease gives you a big pot belly. So you've got a lot of adipose fat there. Now, how are these two things working? Well, both things are true. You break down your fat, so lipolysis, and you generate glycerol, which makes more glucose. So it's back to the feeding the brain with sugar. And you also release lots of these fatty acids. Now, fatty acids can get digested by lots of tissues around the body and used as an energy source. Now, the reason why that's helpful is you now can reserve the glucose for the organ that really needs it, which is the brain, because the brain can't use fatty acids. They don't cross into the brain. So you're now, if you can get your muscles and other tissues to use fatty acids instead, you're now preserving glucose for your brain. So you are breaking down fat, but the reason why you get the pot belly is once you break down all that fat, we're not actually generally in Cushing's anyway, there isn't actually an emergency. You're actually just having a normal life. So it's kind of like, whoa, what do we now do? So what you then do is you store it all up again. So we break down all that fat, make all these fatty acids, preparing for starvation and emergency, but then the meal's around the corner because you've got Cushing's. That survival hormone's not going to turn off, and you then have to do something with all this energy you're creating, and you just store it all away as fat.
And with the pot belly, because you get a hepatomegaly in Cushing's really often, don't you? So generally when you feel these guys on abdominal palpation, the cranial abdomen wise will just feel really firm and full, won't it? It's not uncomfortable, but when you get really good at feeling them, you're like, oh, that liver feels huge because you can just feel it all around the right hand side of the abdomen. And I guess that's why, isn't it? The liver's doing more in terms of gluconeogenesis. It's working more and you're storing up some of that fat, are you? Is that why you're getting that hepatomegaly?
A little bit, yeah, but and yeah, you've kind of got it pretty much because all of that glucose production hasn't got anywhere to go because the patient's eating and doing normal things in a Cushingoid dog, so it gets stored within the liver cells. So the liver cells get full of glycogen, and so they get packed. So that when you do your ultrasound on your liver, you get all these little bright, flecky kind of pattern throughout the liver. And that is basically hepatocells swollen with glycogen. And that's this vacuolar pattern that you get.
Yeah.
So again, it's all down to essentially eating yourself, but digesting muscle and fat, and then having to store all that stuff away in your liver and as fat in your body.
We know that Cushing's and diabetes can be kind of intrinsically linked. We can see one and then the other. And I know that Cushing's tends to throw up insulin resistance, doesn't it? And that's why we end up tending to get an issue if you see that alongside diabetes. But why is that? Why are we getting the insulin resistance?
So what happens is, this is another thing about making sure the brain has a supply of glucose because the brain is so needy. It can only have ketone bodies or glucose for energy. So we don't want the muscles to use glucose if we can help it. So what happens is cortisol comes along and it essentially it kind of gives you insulin resistance in the muscles. Now the muscles need insulin to be able to use that glucose. And if the insulin isn't working, they have to turn to another energy source. And they will use those fatty acids that are coming down from the breakdown of fat instead. And they're quite happy to do that. So as long as you can block the insulin, they will switch and use fatty acids, and then it's going to preserve glucose for the brain. So this is the reason why cortisol seems to have this, seemingly, it's hard to connect. Why does it cause insulin resistance? Well, that's why.
Yeah. And that makes so much sense when you're dealing with your diabetic patients that are also Cushingoid because they're so difficult to stabilize, aren't they, until you get on top of the Cushings because the insulin that you give just doesn't work or doesn't work anywhere near as well as it should do. So just kind of really makes sense as to why that actually happens.
Yeah, yeah. It's like this whole beautiful system has been created, but no one had told me this until I started reading up about it. And I thought, wow, it all makes sense. Then the other thing, and this connects with emergency now, but cortisol is central to maintaining your blood pressure, which am I right? I didn't know this at all. Were you aware of this?
Yeah, but I guess the only reason why is that, or one of the reasons why, is if you think, so we'll do a podcast on sepsis at some point, but there is something called CIRSE or like corticosteroid related insufficiency in sepsis. And basically that's when you get to a point where if you are in septic shock, then often you're in vasodilatory shock. So you have a ridiculously low blood pressure because all your vessels are super dilated. What you do in those patients is, yes, you volume resuscitate them, but often they need vasopressors, so something like noradrenaline to try and get that blood pressure up. But if they're on vasopressors, if they're on positive inotropes like pimobendan to help with cardiac contractility. So you're doing those two things to try and get that blood pressure up as much as you should do and maintain your cardiac output. If you're still then really super hypotensive, then often in septic patients, they basically don't have enough corticosteroids, so they are corticosteroid insufficient. So there's a type of steroid that you can give them, which does help as almost like a vasoconstrictor, if you like. So it helps them to really constrict those vessels down and maintain your blood pressure. So, but yeah, I know that's whirlwind, and we will explain it properly in later episodes. But yeah, it definitely has a massive role to play. Now, I'm not saying give every hypotensive patient steroids. That's not what we're saying, but it definitely does have a role to play.
So, yeah, so all steroids are needed for the sympathetic nervous system to do its job and create vascular tone and support your blood pressure. And without the cortisol, your noradrenaline, which is being secreted from the nervous system, and it's onto those blood vessels, and it's trying to make them constrict and get your blood pressure up, that won't work without cortisol. Now, where this is relevant is your Cushing's dog has loads of cortisol. Then the blood vessels are going to get really super sensitive to all of that noradrenaline coming from the sympathetic nervous system, and you're going to get hypertension. And this is why Cushing's dogs can have hypertension. But where it's also really relevant is Addisonian dogs are going to have the opposite. Now, they haven't got the cortisol. Now you can release all that noradrenaline onto the blood vessels. You can release your adrenaline into your body to try and cause vasoconstriction. It's not going to work because it needs
Yeah.
cortisol. And that's why Addison's dogs have got these floppy blood vessels and hypotension as well. And there's multiple reasons, but that's another big one. So that's another thing where cortisol, is really, really important for maintaining blood pressure.
I don't know if many of you have seen the really nasty Addisonian crisis, but often they need to be on your vasopressors as well until you've got on top of everything.
The last bit about the blood pressure I'll go into is that it's not just the systemic circulation where it's supporting the high blood pressure. You're also getting high blood pressure in the kidneys as well. And this is leading you to your next thing that Cushingoid dogs have. That extra high blood pressure through the glomerulus leads to damage to the glomerulus, protein leakage into the urine, and now you're getting your urine protein creatinine ratio going up because you're now getting protein in your urine, and that's all another function of this hypertension caused by too much cortisol.
A little bit later, we'll go on to how to diagnose Cushing's, but that sort of leads on to one of the ways that you can do, because we can do a urine test to be checking for how much protein is in the urine as part of our diagnostic workups.
How that connects to survival is obviously you want to maintain blood pressure when you're in a massive crisis and emergency. So it all connects back. And remember I said right at the beginning, it's all about making sure the brain has glucose. Well, if you maintain your circulation, you maintain the blood perfusion of your brain and you maintain sugar going to your brain. So it's, it's all feeding that one thing.
And so we've spoken about emergency ways that cortisol can really help, but why do we get the hair coat changes and the skin changes? Like why do we see those changes with Cushing's disease?
Yeah, right. Amazingly, again, it's connected because if you're in a massive emergency or starvation or long-term like chronic difficulties, you don't want to waste time with hair. Hair's just a fluffy, extra, unnecessary thing. And you don't always want to put lots of effort into maintaining your skin either. So two things that happen with cortisol is the hair follicles stop doing their thing, and so you're not producing your hair. The hair follicles kind of shut down. But the other thing is the skin isn't replenishing itself in the way that it normally does, so you thin your skin. And this is why when you're using topical steroids, how they always say they thin your skin if you keep using too strong steroids too much. And that's why, because it's considered like a bit of a luxury when you're in an emergency and you're going to cut back on skin and hair production.
I mean, it makes sense. I mean, you think of me last month when I was revising for my SIR, that was definitely me. No skincare, no hair care. Yeah, greasy and dirty and carrying on with revising. Yeah. So yes, it makes sense.
Yeah, I remember my friend doing his A-levels actually when we were quite young as well. And he woke up before his A-level exams and it was 3 or 4 weeks later and there's a whole bunch of hair on his pillow and he was absolutely horrified. But the stress of the A-levels had made his hair fall out.
Yeah.
Yeah, so and everyone thinks stress makes your hair fall out, but when you think of it in terms of energy conservation, it starts to all make sense a bit.
Yeah. Okay, so I think we've chatted a little bit about how and why these dogs might present the way that they do. And to be honest, even if at this point where your dog has walked into your consult room and you're still not actually sure that it is Cushing's, you might end up doing a routine blood test just to be like, oh, what changes have we got? Have we got any changes on hematology? Have we got any changes on biochemistry? Just to see if you can rule in or rule out some things. And one of the big things that we do see in these guys is that we often see a stress leukogram on their hematology. A stress leukogram, for anybody who's not quite sure what that means, basically is a change in your hematological parameters that is literally influenced by stress, so influenced by cortisol. So it can be for a number of different reasons. That can be physiological stress, but also with your Cushing's patients, it's because you've got too much cortisol. So generally, that's when you get a leukocytosis normally, and that consists of normally an increase in your neutrophils and an increase in your monocytes. So you get a neutrophilia and a monocytosis, and really often that's paired with a decrease in eosinophils and a decrease in lymphocytes. So an eosinopenia and a lymphopenia as well. So normally you see the four of those together. So if you do see the four of those together, and usually they're quite mild changes, you're not talking about an absolutely massive neutrophilia, and that's probably something different. But if you're seeing really mild changes in those directions, then usually it's to do with stress. And Brendan, you've got a little funky acronym that you've got for this, haven't you?
Yeah, I can't attribute this to someone, unfortunately, because I don't know who, but since I was a student, not much eats leopards. And I still use it to this day. Not much eats leopards. The first two go up, neutrophils and monocytes. The last two eats leopards, eosinophils and lymphocytes, and they go down. And just by the way, how many times for me, I've gone and I've seen an Addisonian dog, I've gone onto the white blood cells, and you do see the eosinophils are up a little bit, or the lymphocytes are up a little bit, and the
Mm,
neutrophils are down. So you get the opposite. Now, I'm not saying
yeah,
every Addison's has the opposite, but I've definitely seen the opposite as
yeah.
well. So not
Well,
much
I
eats
think
leopards. Yeah.
Yeah, I think for me, we see stress leukograms so often in unwell patients because their body is under physiological stress that for me, actually, if you've got an Addisonian patient, a dog that comes in that is that sick, if you have an absence of a stress leukogram, that makes me think it's probably Addison. So even before I checked my sodium and my potassium, if you've got an absence of this, that actually tells you a hell of a lot anyway. So when you're checking your hematology, be thinking, can I see one? And if I can't see one, is it normal that that I can't see one? Because we see this really commonly.
Yep. And if just in case you were thinking that Brendan's gone off the track on his crazy notion that this is all about making sure that the brain gets glucose, I haven't, because this is also connected. Amazingly, another way of saving energy during a crisis is to calm down your rather sophisticated adaptive immunity. That's the immunity you get by your principally mediated by your lymphocytes. Also think eosinophils controlling parasites. These are not these are things that we can calm down. We don't need to be doing them. We don't need to waste energy on them. What we do want to maintain, however, is the innate immunity. It's lower energy. It's easier to do. It's the neutrophils and monocytes just going around the place, eating things up. Really simple, low energy. Let's do that. Adaptive immunity involving antibodies, lymphocytes, lots of bone marrow upregulation, and all of this. That's much more sophisticated, much more energy demanding. That can wait in an immediate survival sense. So
Mm.
this is the origin of where the stress leukogram comes. So yes, again, it's cortisol telling the body, let's focus on the basics. Let's not try and be too fancy. We haven't got enough resources to do everything.
Yeah, yeah, it makes sense.
Okay, so the main things we get are skin infections. You get dermatitis, and I don't know, I always see it on the pores. I don't know, maybe I've had it periocular as well. And then urine infection. So we'll come back into that because that's a little bit of a nuanced one as well. So these are the ones we see. Funnily enough, this is not like your chemotherapy patient with marked neutropenia, immune suppression, pyrexia. They get these quite low level kind of problems. And it does rather spring from everything we talked about, because if you think about Demodex, it lives down the hair follicles. Now our hair follicles are they're on down regulate. They're just these empty little shells, and all the immune surveillance is gone. They're not doing anything active, and it's like, Demodex mate, I'm going to live down there. It's kind of like it's uninhabited, easy place to dwell. So Demodex comes in, skin infections coming in as well because of the downregulated immune system, but also the thinning skin. So you've got also that kind of factor, and the urine infection. We're going to come back into these dogs drinking a lot, weeing a lot, but it's diluting the urine. You've got less immune surveillance going on. We've got more skin infection, maybe for ascending bugs, bacteria and yeast to kind of go up. So we've got this increased pathogens in the urine as well. So yeah, so to help you remember anyway, so you've got the skin infections, the Demodex, and the potential urinary tract infection.
And I guess it's worth saying here as well is because you can sometimes get your Cushing's and your diabetes hand in hand, is it's
Uh,
always worth checking
yes.
if you are getting UTIs, double check whether you have any glucose in your urine as well, because you could be getting a UTI because you've got concurrent diabetes rather than because of the Cushing's on its own anyway. So they can be a little bit intrinsically linked like that, can't they?
That's such a good point.
And then one of the things that I maybe realized more recently in my career is the importance of using anti-clotting drugs on these guys as well, sometimes in terms of our management. And we'll get onto the drugs that we might use a bit later. But I know that obviously Cushing's, like you said before, can lead to protein losing nephropathy. So you can get to a point where you're getting lots of proteinuria. And sometimes that can put them into a hypercoagulable state, can't it? But why is that? Why are we seeing that with cortisol? With an increase in cortisol.
Yeah. And again, it just is so obvious when you think about it, because in our ancestral kind of life, if we were under massive threat, then we presumably will be at risk of bleeding, trauma. So suddenly cortisol is really helpful because it's going to increase the production of several clotting factors. It's increasing your blood pressure, which is potentially going to be more damaging to blood vessel walls. So yes, it's great that we're getting all this extra clotting ability, but when it's there for months and months, this is also going to make you more prone to having a blood clot. And with protein losing nephropathy, when you're losing protein through your kidneys, you're also potentially going to lose antithrombin 3. So that also makes you more likely to clot too, because that's normally there hanging around, stopping you clotting unnecessarily.
Going back to, so when we said, okay, these patients are going to present, maybe you'll be like, oh, is it Cushing's? Is it not? You might run a full blood panel. So you might do a CBC, full hematology, and a biochemistry, maybe a Chem 17, for example. So if we're talking more about our biochemistry now, what else are we likely to see on there if we have a Cushing or a dog? You know, I know that we've said that it can affect the liver. Are we going to see any changes to liver parameters? Are we going to see any changes to fats or to proteins? Or what generally are we going to look for on our biochemistry?
Yeah, so we're breaking down our fats. And because we're not utilizing all that energy in the Cushing's dog, we then have to repackage the fat up that we've broken down really carefully and produced all these lovely things to produce energy from, repackage them up and send them back into fat stores. So in the blood, we're going to see that fat. So we're going to see it as both as cholesterol, so raised cholesterol on our biochem, and the sample's going to be really fatty, which is your hypertriglyceridemia. And it can interfere with your biochemical analyzers. So, and I think this is really noticeable, isn't it? In a lot of endocrine cases where you get this really fatty sample when it settles out.
Mm.
The obviously the one we're all looking for, the really high ALKP, high alkaline phosphatase. That one is a really weird one because you think, well, you've got hepatomegaly, all the liver cells are all swollen with glycogen. Maybe that's contributing a little bit to this raised ALKP, but actually most of it is this weird thing that as far as I'm aware, only dogs do. Dogs upregulate, start making more alkaline phosphatase in the presence of cortisol. But it's a purely dog thing. Cats, humans don't do it. I don't think horses do it either. And I don't think anyone's quite worked out why.
Yeah, the thing that makes that interesting is that you don't normally expect the ALT to be elevated, do you? So I think yes, the liver is involved in all the ways that we've been speaking about, but the reason it is a bit strange that you get this massively, and sometimes they can be like in the thousands high ALKP, can't they? They can be massive, the sort of level that you're seeing, but your ALT is normal. And if you scan them, generally they don't look like they're in cholestasis. Their gallbladder looks okay, so you're like, well, is probably just because of the Cushing's. But yeah, it is a really strange one because you look and you think, oh God, and you have to rule out, is the bile duct going to become obstructed? Is there a horrible issue with the liver? But the ALT is always fine, normally, anyway.
Yeah, so do you know one thing I learned last year? I did read from someone reputable because I used to think if the ALKP was normal, that wasn't going to be Cushing's. It was a rule out. But I did read one specialist said that it can still happen. Not every dog has this canine thing where they get more alk phos because of
Mm.
steroids. So just bear that in mind, because obviously then for me, all these years, I never tested them if the ALKP wasn't up. I mean, I think they're rare, but have it
Yeah.
on your mind.
Yeah, I think where I'd take that is that if, for example, I had a dog that I was pretty convinced was Cushingoid and its ALKP was normal, again, we will talk about exactly how to diagnose Cushing's in terms of the definitive test that you want to do, but I'd maybe go for testing to rule it out rather than to rule it in. So I might go like a cheaper urine test rather than your full-on blood test, which we'll get to in a minute. So yeah, it just makes it a bit different in terms of how you might do the workup. It doesn't mean that you necessarily wouldn't do workup for Cushing's just because that ALKP is normal.
Yeah, just much lower on your list, I suppose. But
Mm.
yeah, so this kind of takes us a little bit through. We've talked a bit about the loss of muscle, the big liver, and the fat. Into this is one of the reasons why you have panting as a really common sign with steroids. Oh, do you know what? This isn't 100% true because as I think about it, so you've got the increased metabolic activity. You're breaking down your fat and your muscle. You're doing a lot of energy demanding processes. That heat production is making you hotter. And you've got all this better insulation around with all the extra fat, so you're panting to cool down. But the panting, I notice, you'll get it on day one when you give an animal high dose steroids as well, won't you?
Yeah, but I think, I mean, if I'm using high dose steroids, if I'm doing it in emergency work, there's not many cases that I'd use it for. But if I do, then I might be like, oh, it's probably on methadone or something as well, in which case I'm just probably panting for multiple reasons, or because it's got some horrendous metabolic acidosis and it's trying to blow off all
Yeah.
its CO2. Yeah, it's, yeah, I think I've never really thought about attributing it to the steroid as such, but yeah, I guess it could be. So, because we do see the panting so much in your Cushingoid dogs.
Yeah, well, it's us older vets that reach for prednisolone more than you guys. So we're used to the clients talking about the panting. I've kind of skirted around one of the biggest things, which is the PUPD. So why do steroids make you drink a lot or wee a lot, or which one are they making you do?
I think it's one of those things that everyone learn at vet school, but whenever we talk about the RAS system or ADH or vasopressin or anything, everyone just goes like, and it was always something that we learned, and then everybody chose to forget really, really quickly, or I did anyway.
I'm impressed that you were taught it because I mean, obviously it's decades ago, but I didn't get taught this. I don't. Well, at least maybe I did switch off. So this is what you were taught, yeah? That cortisol suppresses ADH or vasopressin or whatever Americans might call it. See, I never knew that at all. So just for people who don't immediately know what ADH does, ADH is antidiuretic hormone, and it comes out the brain, it goes over to the kidneys, and it opens up little connections between the collecting tubules into the collecting tubules of the kidneys, and it allows the body to withdraw water from the urine into the body again. And when you don't have ADH, or vasopressin, you have this condition called diabetes insipidus. And that's either caused by a lack of ADH coming out of your brain or your kidneys not responding to ADH in the right way. But that's diabetes insipidus. And you wee lots because you're now no longer grabbing that water out and holding it back into your body. So, cortisol, why on earth, it took me ages to puzzle this out, why on earth would it antagonize ADH? Why are they acting against each other? And Joe, do you know, I don't know if you know this, Charlotte, this is where it fits in with blood pressure again. So we talked about adrenaline being released to improve your blood pressure, to constrict your blood vessels, and noradrenaline coming out of the sympathetic nervous system and going onto the blood vessels and constricting it. The other drug that's used in emergency medicine, vasopressin or ADH, ADH has that role too. So in an emergency, you spike ADH, and ADH actually has that constricting effect on blood pressure too. And the other thing it does is it grabs the fluid that you were going to wee away and holds it in your body, which is pretty useful thing to do if you're about to bleed all over the place.
Yeah, so in emergency medicine, people might use vasopressin. They don't use it very often because it's mega expensive from what I remember. But yeah, so it is used in that respect because you want to hold on to your water and everything that the blood is carrying and get it to where it needs to be, get it to your brain, get it to your heart. So yeah, and that's why you get that constriction with it too. So
now let me remind myself because I did eventually puzzle this out. It took me a while. So why cortisol kicks in now is it's a little bit like you need to counteract this, because if you have got loads of adrenaline, noradrenaline, like pumping through your body, all your vessels are constricting, you're holding on to every drop of water and not weeing anything out, you could go dangerously into too high blood pressure. And where cortisol is coming is it's like the physiological brake. It's kind of like, hang on a bit, this is going too far. We now need to just hold back on holding all this water in, or you're going to get too hypertensive. And we need to do some weeing out and get our water balance about right. So it's kind of like
Mm,
it's the balancing with the ADH effect is where it's
yeah.
coming from. So
And it is
yeah,
it is such a fine balance, isn't it? Because when you think about that Cersei in sepsis, we're using it basically to help maintain our blood pressure. So to basically do the opposite of what we're saying right now. So it just shows that it's not cortisol and nothing else acting. It's everything within the body is in such an intricate balance, isn't it? And it's when you get one of those things that's not quite regulated the way that it should do, that's when everything goes a bit to pot. So it's really interesting.
yeah, exactly. Understanding how this whole system is put together really helps you understand what these diseases are and what our drugs are
Mm,
doing, don't they?
yeah.
This is why I was just blown away by this topic. So yeah, so one of the hallmarks of Cushing's, and it's really you must have this to investigate Cushing's. You must have PUPD. Is
Mm,
if you do not have PUPD, do not start looking for Cushing's because Cushing's is not a disease to be looking for unless you've got your ducks lined up. And I really want to hear the owner kind of commenting that the dog's emptying the water bowl unexpectedly or weeing
mm,
in 4 in the morning or whatever. And yeah, this is all because of that ADH antagonism. Okay, and so the very last bit here is Addison's, which is going to be the flip of this. One of the now look, I think most of us think Addison's dogs get low sodium because of the aldosterone deficiency, but atypical Addisons can also get low sodium, and it's because of this same problem. So when you don't have the cortisol, you don't antagonize the ADH, you start retaining lots of water in your body and you dilute your blood. So now you're just diluting your blood, so your sodium's dropping lower because you're bringing in free water into your blood. So that's a part of the reason why Addison's dogs have low sodium because of
yeah.
the lack of ADH control.
And for anybody who's like, oh God, well, they haven't really covered Addison's, we are going to be doing a whole episode on Addison. So that is to come as well. So you can hear Brendan getting more excited about another topic then as well. So yeah, but we'll talk through it all in more detail. But we're hopefully going to go through acid base disturbances first because that will make Addison's make a bit more sense. So that will be coming later in the year. So look forward to that.
Right, we better get on to testing. So we've got
Yeah.
our dog that's classic Cushing's, and we know why. So we've got 2 tests, haven't we? Does
Yeah.
every vet have their favourite test, I feel?
I have never done the low dose DEX test. I've never done it. Yeah,
Wow.
I don't do it. I think for me, I do the ones that I want to rule out Cushing's. I do your urine protein creatinine ratio. That's the one that I'll do because it's lower cost than if I'm just ruling it out. If I'm ruling it in because I'm thinking it's really, really likely it's Cushing's, I'll go straight for ACTH stim.
I think you represent most vets. I really do. However, right, this is one of these silly anecdotal things, but because I had the first 2 or 3 ACTH stim tests I did, I think they all had like borderline results or something. And I ended
Mm.
up then having to go to the client, say, oh, actually, can I have the dog in for another 8 hours, do another really expensive blood test? And then we will find out if we have got Cushing's. I
Mm.
think it turned me off. Now, I could have been unlucky, but I just found that the low dose Dex was helping me because if it told me I didn't have Cushing's, it was really good. And I just trusted it. I just trusted
Mm.
it. And it gave me a little bit more info as well because it can help you differentiate between pituitary and adrenal.
Yeah,
But I
yeah.
found the ACTH wasn't always, have you not had like, it's a little bit unreliable, the ACTH stim.
I mean, to be honest, again, there's not been that many. I can think maybe actually there's probably only been one patient that I've actually fully diagnosed with Cushing's, to be fair. I think the rest, like I've always tested for it if I've been worried that it is, but normally it's not come back as positive. And the only one that I actually did do that came back as Cushingoid was one that was already struggling with diabetic management anyway, and that case didn't end up that well, I don't think, for various other reasons. But yeah, so I mean, and that's the other thing to remember as well is that not only are we trying to work out whether something is Cushingoid, but we're trying to work out why it's Cushingoid in terms of what part of the body is going wrong. And that all comes back to that HPA axis, doesn't it?
Yeah. Should we explain how these tests work? Because I think it does help you get your head around it.
Mm,
Because this is kind of going into what you said, because the hypothalamus secretes CRH, corticosteroid releasing hormone, or something like that, and it goes into the pituitary. The pituitary then releases ACTH, and the ACTH goes to the adrenal cortex and tells it to make cortisol. And then the cortisol would feed back into the brain and kind of go, when you've got lots of cortisol, it'll kind of go, right, stop your production of everything now. You need to calm back down. So that's like your kind of classic kind of feedback loop. So when you give a patient low dose dexamethasone, That's like you're feeding back and you're saying, right, hypothalamus and pituitary gland, stop making all your stuff. We don't want to make any more cortisol. And what's meant to happen is your cortisol level drops for over 8 hours, which is why you're meant to get to normal cortisol levels or to low cortisol levels on the subsequent, the 4 hour and the 8 hour. And why in Cushingoid dogs, you will escape the negative feedback. So the dexamethasone isn't as strong. It doesn't, isn't able to stop that pituitary from secreting ACTH. And so the pituitary will carry on releasing ACTH and the adrenal glands will make cortisol. Or if you've got an adrenal tumor, it's not going to feed back onto that at all. It's just going to crack on, keep making cortisol, which is why an adrenal tumor will typically give you your 4 hour cortisol and your 8 hour cortisol as high, because it's just making its own cortisol. It doesn't care about dexamethasone. Whereas the pituitary ones will often have some suppression because the pituitary is responding to cortisol, but it's not the normal kind of response. And it will, by 8 hours, they will escape and start making ACTH, and then you've got your cortisol.
Oh, okay. So when you send this test off to the lab, so say if you were, I don't know, sending it to IDEX or whoever, and then your response came back in your thing, like when if you get like a hyperthyroid or whatever, and it will have your normal marker, and then it says over this would be suspicious of this, over this would be suspicious of this. Do you get, after your low dose dex test, you get a result that says if it's between this level and this level, would be worried more about pituitary, this level and this level would be more about adrenal? Is that how it will come back?
I think so, but it's not quite as easy as that because, look, this is where you need to know a little bit about which ones get which, I suppose. But because most dogs get the pituitary form, even though adrenals are much more likely to just crack on and give you high cortisol at both times 4 and 8 hours, because a few of the pituitary also do that, when you get one that escapes and gives you high cortisol at 4 and 8, it's 50-50. It could be adrenal, it could be pituitary. But then you need to look into context. If it's particularly the large breed dog, not your classic kind of Cushingoid Bichon Frise or whatever, and small breed dog. If it's your large breed dog, and you then get this high levels of cortisol at 4 and 8 hours, I think you should be thinking a little bit more, this could be adrenal. And the adrenal ones, the relevance of that is they're not going to respond as well to your medical management. So you're going to start losing your client. Client's going to be going, oh, it's not working that well, or you'll get an okay month and then a bad month. So it can be quite useful to have an idea if they're adrenal, because at that point, imaging's on the cards, and surgery, if you've got the right owner, is a possibility. And you can also talk them through that medical management might not go quite so well, but you can give it a crack.
Yeah.
But you might have lower expectations.
Yeah. And if we circle back to imaging in a minute, so how we've just spoken through how your low dose dex test works, when we're then talking about our ACTH stimulation test, in a way it's almost working, but in the opposite way to what a low dose dex test would do, isn't it?
Yeah, I'm not as good on this. Now, so you're giving them ACTH, and I assume with Cushing's, you're going to have a bigger impact and it's going to go crazy. So your cortisol's going to go sky high, really, really loads. But thing is, I do think quite a few Cushingoid dogs just don't do that. I think what the ACTH stim test is really good at is telling you, are my adrenal glands functioning at all? I think it's good in that context. So your Addisonian is spot on and it's not going to fail. If you've suppressed your adrenal glands or they've got no cortisol to give, your ACTH stim is going to be great. Have you got any active adrenal gland? But this idea that Cushingoid dogs go and you give them ACTH stim and they pump out loads of extra cortisol, well, it does happen, but it's not it's not totally reliable. When it does happen and you get a really good response to ACTH stim, then it is accurate. That patient is Cushingoid. So that's the good part of that test. So don't get me wrong, it's got value.
Okay. Yeah, so I think basically how it would normally work is that if you had a normal, healthy patient, then your cortisol will still rise, but it will rise to a moderate, so to a normal level, like you're expecting a normal body response. So it's not that you're not expecting a rise at all, but you're expecting a normal rise in sort of conjunction with how much ACTH you've given. Whereas in Cushing's disease, because you've already got that high level of cortisol anyway, and you're basically expecting that massive exaggerated response. So it spikes to an abnormally high level after the injection rather than just rising slightly. So it's not the rise, it's the degree of the rise that you're looking at. And then obviously, if you're looking on the flip side of that, if you were looking at Addison's, you won't get any response to that really. So the cortisol will stay low and it won't come up after the injection, which tells you that your adrenals aren't working properly. So it's more about the level of the rise of cortisol rather than the actual rise itself, isn't it?
Yeah, like a big exaggerated response. But this I was
Yeah.
chatting to a vet last week actually, and she was saying how she always uses urine cortisol creatinine ratio,
Mm,
and I thought this is a really clever. This isn't about the medicine here. This is about the client. I think you can manage the client really well because if you've got a urine test where basically the urine cortisol creatinine ratio is just giving you an idea of your average cortisol over a period of time by looking at the
mm,
cortisol level in the urine. And we know that this is a test that is a really good rule in. All Cushingoid dogs are going to have a raised urine cortisol creatinine ratio. The only problem is lots of other dogs will too. But if it is normal, that dog does not have Cushing's. And that can be
mm,
really helpful for a client because some of these cases, the dog is quite well and you
mm.
have to bring the client with you. And if you can do a non-invasive test where it's just a urine test and it comes up positive, I think it's then really easy to say to your client, well, look, this dog might have Cushing's because this test came back like this. It may not, but I think it's good evidence to say, how about we do a blood test to
Yeah.
find out for sure? I just think it's yeah. I think that can work for a client? You know?
Yeah, and I actually just realized, I think when I was speaking about urine tests earlier, I meant urine cortisol creatinine. I think I might have said urine protein creatinine at some point, but I mean cortisol creatinine. And I actually use UCCR quite a lot, to be fair, because I find, to be honest, like an ACTH stim is quite expensive. Like to get the ACTH injectable is quite spenny.
Yeah.
And a lot of people, because especially because they're well, it can sometimes be quite a battle to get clients to want to test for Cushing's because they're like, well. So they sort of don't really want to be spending 300, 350 quid on a test if they're like, oh, but they're not really sick. Whereas if you can say, okay, well, we can send a quick urine sample off to the lab, which isn't invasive. And if it comes back as positive, like you say, I'd say, it's probably quite likely to be Cushing's, but we just need to double check. Whereas if it comes back negative, I can say, great, they've avoided that really expensive blood test. Because if it's negative, like you say, I use it as a rule out. So it's quite good for those cases where you're like, should I be worried about Cushing? Should I not be? Because if it comes back as negative, you can be like, great, I've saved them an ACTH stim. Whereas if you really think it is Cushing's, it wouldn't be my first go to because if it comes back positive, you're still going to have to do your ACTH stim or your low dose Dex anyway. So
Yeah, definitely. Well, should we use this moment to go into endogenous ACTH?
mm,
Because I've done this test 3 times and I refuse to ever do it again because every
I've
time I've
literally
done
never
it,
heard of this.
oh, I think, you you used to have to send it to Cambridge Specialist Labs. I don't know what they're called now, but you do have to send it to you have to go through so many hoops to do it. Cause I think I remember I gave the nurses the instructions and they were cooling the centrifuge and you have to put it into ice straight away. It's one of these. You've got to do everything right. You got to get a courier. You got to get to the lab quickly enough. So it's a real faff to bother her. And they say, I've gone to all the trouble of doing it 3 times and every case had an intermediate grey zone answer. So the idea of endogenous ACTH is exactly that. It's measuring your ACTH level that you're naturally making from your pituitary gland. And kind of obviously, if you have a pituitary dependent Cushing's, you're going to make loads of ACTH, so it should be high. If you have an adrenal tumor, you're going to be producing loads of cortisol, which is going to shut down your ACTH stimulation from your pituitary, and you're going to have low ACTH. So it kind of makes sense. This should be a great test. But I say
Mm,
the 3 I've done all were in the grey zone. And I think it's just, you've gone to all that trouble. You've cost the owner a load of money and
mm.
further on. And I think, yeah, if it was more frequently helpful, great. But yeah,
Yeah,
that's why I'm a bit off
more
it.
people would be doing it if it was super useful, wouldn't they? So it's
Yeah.
yeah, it's something to bear in mind, but not necessarily the thing that you'd reach for first. So
Yeah.
yeah,
So
okay.
yeah, this brings us on to, so this is all about differentiating. Have you got the pituitary or the adrenal form? And then the other big way we do this is abdominal ultrasound, or for a lot of people, because adrenal glands are so damn scary for ultrasound, so difficult.
Mm,
CT. It's like, oh, why don't we just do a CT? It's so much easier. So yeah, this is kind of springing up, and I hadn't really kind of got my head around what I would do in the modern era with these Cushing's patients now. Whether you would, so I don't know. My take on it is if it's a small breed dog and I don't know, it's 13 years old. The owner's unlikely to be going crazy with surgery and epic things. I might just go, look, it's probably a pituitary tumor. especially if I've got suppression at 4 hours on my low dose dex and it's escaped at 8 hours. So that's not normally what an adrenal tumor would do. I might just go, look, 85% this is going to be pituitary. Let's treat it
Mm.
as that. We'll come back to this if I've got it wrong, but that's a reasonable approach, I think. Because it's really important to remember when you do your scan, these adrenals can have such variable appearances, and it doesn't 100% help you tell whether it's Cushing's or adrenal tumor. They're much more complicated to interpret.
I think as well, it comes down to how much people want to spend the money as well, doesn't it? Because you might actually be saying in some cases, well, we know it's Cushing's, we don't quite know whether it's pituitary or adrenal. But if you don't want to do any more workup at this point, then let's try some medication, see how we respond. Because ultimately, if they're responding really well to medication, like, does it massively matter? Because you're making them feel better and you're treating some of the symptoms. So, like, does it massively matter? Whereas, yeah, I think if we wanted to go that horrible gold standard term, then yeah, imaging to work out exactly which one it is ideal. And to be honest, I'm not going to be scanning them because I wouldn't be able to tell you if I'm seeing an adrenal tumor or not. I'm not good enough. But yeah, I think that people that are great at scanning, then it seems like the most sensible first step, doesn't it?
Yeah, I totally like what you're saying. I think that's true, and I think when I'm reading through this myself for this episode, I thought, look, if I get a large breed dog, I do my low dose dex, and the cortisol's high at 4 hours and 8 hours, so it's just not responding to dex suppression at all.
Hmm.
Maybe I'm going to have a good chat with my owner and say, look, this is a bit suspicious. We've got an adrenal tumor. This might not go that well. What do you want to do? Because if
Mm,
it is an adrenal tumor, would you do surgery? And then
yeah.
look at the insurance part and look at how much their funds are and ask them if they want to have a referral ultrasound or a CT. And then that's my probable take on how to do it, I think, which I think fits with how you would go about it too, doesn't it, really?
Yeah, yeah. And I think you've also, so I know we were going to speak about in the pod sort of potentially if you were wanting to sort of teach yourself how to be looking for these on ultrasound, exactly where you'd look. But I think maybe because Brendan always does these amazing blog posts after each podcast, so that maybe we'll go into a bit more detail on the blog post rather than sort of talking you through it blindly and taking ages to chat through how you do it. Because some people are probably just going to go, yeah, we're never going to do that ever. But if you are interested, then have a little look at that blog because I think it's definitely something that you can try and learn how to do. I personally am not very good at it, but I think you're much better than I am.
No, I'm not very that good, but the left one is more doable because it's kind of sitting in a nice position because the right one is
Mm,
tucked up under the rib cage a little bit. I think you need
mm.
to sedate your patient and just give yourself loads of time.
Okay, so we've chatted a little bit through sort of how these dogs are going to present, how we can work them up in terms of blood tests, the testing that we want to do to try and diagnose, and then maybe touch on imaging. So maybe we need to think about how we're actually going to treat these guys. So if we're thinking about medical management, I mean, there is sort of one drug really that is our mainstay of treatment, isn't there?
I think there is trilostane, yeah. Now, well,
Mm,
there is now. It used to be mitotane, which actually was a wonderful drug to use. But yeah, so now it's trilostane. I thought this was twice a day. I think when I was reading up about this, people do it once a day as well. But yeah, and so then you get into the monitoring and how you monitor them as well. Because obviously, if you go too hard with your trilostane dose, then they're going to go Addisonian, and that is a crisis. So it's really important not to go too heavy with the dose. So build up to it. Uh,
even just looking at like one of the common data sheets now for one of the particular brands that we
oh
might
yeah,
use, I think they generally say that the starting dose is normally about 2 mg per kg. And this one particularly says give it once daily with food. And to be honest, they normally say in terms of monitoring. So this data sheet basically says you should take biochemistry, including lights and an ACTH stimulation test pre-treatment, and then at 10 days, 4 weeks, 12 weeks, and then every 3 months following initial diagnosis and after each dose adjustment. But the tricky thing is that's quite a lot of testing and a lot of money for people to do. So it's going to depend on, if you've got an aggressive dog, you're not going to be having them in for an ACTH stim every few weeks, are you? Or if you can't get blood off it, or if they've got no money, or so I think yes, your data sheet gives you the most ideal, and it's going to give you the best monitoring ideally, but nothing is perfect, is it? So Yeah, I think the main thing is check your data sheet to see exactly what it suggests for the particular drug that or particular brand that you're using. But I think there is a little bit of give and take with this, isn't there?
Yeah, that's good that you found that you saw that actually. Yeah, I feel like as well. I think you know when we had those synacthin shortages, and then the labs were kind of like, look, you don't need the synacthin, just do a cortisol before the next trilostane's due. And I feel like they kind of let the genie out the bottle then, because I do think that is a pretty valid way of monitoring these as well. And I don't think you need the ACTH stim to monitor them. There's one trick I have, which if you have a one dog household, and I do this for my diabetics too, get them to measure the water intake before treatment over 24 hours, a couple of times a week, and then whilst you're treating. And it's a really nice way of seeing the water intake going down. And just
Mm,
make sure they do it and they measure it and they write it down and that you want to see it, because you tell them that and then they come in with their bit of paper and they've written it all down. So you've got them on, and I think it's motivating for them too, because when they start
mm,
seeing it coming down, they're like, oh, yeah, it is working. So
yeah, yeah,
that's a really easy one. Measure water
mm,
intake. Yeah. And then maybe these just pre-dose cortisols rather than, if you did want to save the onus of money. And they do
yeah,
seem pretty helpful in helping you decide. And then
yeah,
obviously you've got to have those symptoms of Addison's in your head at all times,
yeah, yeah,
which
exactly.
you'll know very well.
And I guess in terms of when to monitor, because that's always another question, isn't it? Is of when do you take these tests in relation to drug dosing? I mean, this particular data sheet, for example, again, check the data sheet for the drug that you're using. But this one suggests trying to get owners to dose them in the morning, because then if they dose them in the morning, then you can do bloods 4 to 6 hours after administration of the last dose. So that probably makes the most sense. Whereas obviously, if they were giving it at 8 p.m. at night, then you don't really have an option unless you want to do it in out of hours. So, which most people don't. Yeah. So
Yeah.
I'd say, that would probably make sense. So,
Yep, that's true. Yeah, that's true. Unless you're doing your pre-trilostane cortisol, but even then, it might still work. I haven't, even over all these years, I don't feel I've done that many Cushing weight dogs. Maybe one every 2 or 3 years.
yeah.
Um,
Again, it's kind of like, when we were talking about hypothyroidism, how like vet school,
yeah,
it gets like, oh, this is really common. You'll see it all the time. And I think we do see Cushingoid dogs, but I think we don't see as many as I expected to see. Yeah.
but the dog population's changing too. I mean, I think less Westies, more Frenchies, more pugs. I don't know. I
Mm,
wonder if that's an element of it's actually is getting less common.
yeah. Yeah.
But yeah, I think the water intake goes down. The fat, the loss, the improvement to the pot belly and the hair is obviously going to take 1 to 2 months. Uh, that's when we more 1 to 3 months kind of level. But the water intake usually goes down fairly quickly.
Mm,
Um, yeah, there we are. And then Addison symptoms, I always really drill into owners. Look out for these 4 symptoms. And as I tell them, often you'll get all 4, but any of
mm,
these, be on high alert. And it's not eating. I say inappetence. They always go, what? And I go, not eating, vomiting, diarrhea, and lethargy. Those are the 4. And have that drilled into your own head as well. Not,
mm,
because they are absolutely never forget when you've got a Cushing patient that you're looking out for those symptoms, because if you do
yeah.
not want to miss if they're going Addisonian.
Yeah, exactly. And just if in doubt, tell them to stop the trialostane and get the dog rechecked if in doubt. So don't tell them to keep giving it because it will be a lot
Abs
worse if you do.
Oh, totally. Great advice. Yeah. Yeah.
Yeah.
And then while you're waiting for your bloods, then yeah, you could even start on a bit of prednisolone, physiological dose,
Yeah,
if
exactly.
if
So
you're really suspicious. Yeah.
yeah. The one question I always have though with these is because so many people come in and you think it's Cushingoid, but the owners are like, well, the dog's fine, don't really want to go through all this testing. What's the point? Or it's like a really old dog and they think, oh, it doesn't really matter that they're weeing a lot, don't really mind. And you think, well, how do I explain to you that this probably isn't great for your dog to be living with ridiculously high levels of steroid all the time? So, I mean, what would you be most worried about if an owner is not wanting to treat these patients?
You know what? They don't have to, do they? I suppose I always start off with the premise that, look, it's that they don't have to. And then from that, I tend to focus on loss of house training.
Mm.
I think that's the biggest issue. I think that's very universal. And I generally say things like, I do this with hypothyroid cats as well. Say, do you know what? They're actually not much fun to live with. Trying to put it from the
Mm.
owner's point of view. It's actually quite hard for them and it's quite hard for you because now they're drinking endlessly. They're needing to wee all the time. They're weeing in your house.
Mm.
They're panting really loudly. You were enjoying your dog walks and now they can't go very far. It's actually better for both of you to get the treatment
Yeah.
done. I don't know. That's probably, and I think same for hypothyroid cats. They're a pain to live with. How many really old cats that are possibly hypothyroid, and the owners are like, "Oh, I don't want to stress her out." And you're like, it's not fun living with a hypothyroid cat. Well, really often prior to treatment, you'll do your urine test and you'll get bacteria in the urine in Cushing's dogs. Now, you don't often get lower urinary tract signs. So there is a bit of a question mark about whether you're going to reach for antibiotics or not when you haven't got lower urinary signs. Let's say you don't have blood in the urine, you might have protein, but without an active white blood cells in there, without signs of lower urinary tract disease, should you treat the bacteria in the urine is the issue. I know.
Yeah. And are you basing the decision to treat on culture, or are you basing it on microscopy, or what are you saying? What are you talking about when you're talking about
No,
bacteria?
I think nowadays, I don't know if I'd be rushing to culture in the way that I used to. I think if there's no lower urinary symptoms and the sediment didn't have white blood cells in,
Mm.
even if I had bacteria, and nowadays, we do, you've got those lovely machines that will automatically tell you about all the bacteria in there.
Mm.
Yeah, I think I'd be inclined to hold off. I don't know. Yeah, what would you do?
Yeah, I mean,
Do you think?
maybe it is if they've got no lower urinary signs. I'd check there was no glucose in it, so you've not got anything like concurrent diabetes going on or anything. But if you've got not an active sediment as such, like you say, like there's no white blood cells in there, then maybe you do just say to the owner, keep them informed and say, look, there is a bit of bacteria in here, but there's not really symptoms for us to be treating at the moment. So let's just keep an eye on it. Maybe you start on the medication, like you start on trilostane, and then a couple of weeks later, you reassess the urine. And obviously, you just mentioned to them if they start to develop any straining or whatever in the meantime, then you reassess it sooner. But yeah, maybe that is the way to go if we're trying to be really careful.
Yeah, and then if you might also get if the urinating in the house has just gone up a massive level and they're now doing
Mm.
it endlessly, okay,
Yeah.
that could be your signal to go, do you know what? Those bacteria in the urine, maybe we will
Yeah.
treat them with a short course of antibiotic.
Yeah. Yeah.
So yeah. So yeah, that's another one. Blood pressure, keep an eye on that, but hopefully that will come normal once you treat
Absolutely.
the Cushings.
Yeah. Always check blood pressure.
Yes,
It's
that's
my
your
favorite thing.
favorite. You were going in to say something about how you might use antithrombotics in these. Is that right? Were you about
Yeah,
to say that?
so sometimes you can do. So it's quite important in your protein losing cases. If you have like a massive protein losing nephropathy or protein losing enteropathy, that there's an argument that potentially we could be using these in our AHDS or HGE type cases as well. Because generally when you have a protein losing issue, you do go into a hypercoagulable state. So using clopidogrel is probably not a bad idea. But again, it's very case dependent. I wouldn't be using antithrombotics lightly. Think about it. And if your dog's clinically well, then maybe it's just a discussion you have with the owners because obviously once that protein urea comes down, then obviously I wouldn't be keeping the dog on a clopidogrel anymore. So very case dependent. Use it, sort of assess the patient and have a discussion with the owners and talk about it with your team, etc. To decide whether you're going to use it. Don't blanket use it for every case, but it's something to consider. So yeah.
When you say that, the way I can always remember this because I had a greyhound come into me. It had a massively painful, acute onset pain in its back leg, one back leg. And we were like, oh my God, is it a bone tumor that's fractured, pathological fracture or whatever? X-rayed it, completely normal. And we worked out because its paw was cold, it was a blood clot to its back leg.
Mm.
And then obviously from that, we were like, oh, crikey, it's got blood clot. That takes you to protein losing nephropathy and Cushing's mostly, I think. So then we did it had glomerulonephritis, which I think is quite
Mm.
common in greyhounds, a protein
Yeah.
losing nephropathy, and yeah, loss of antithrombin 3. So it got a blood clot. And it's like,
Yeah. And
wow, when you have that, you never forget.
Yeah, exactly. And like you can see it in your IMHA cases, I mean, there's so many different cases where you might be considering antithrombotics. So yeah, bear it in mind, have a discussion with the owner. But yeah, it's definitely something I'd consider.
Yeah. Why in your IMHA cases then?
So in your IMHA, they generally just are in a hypercoagulable state, but definitely don't use it if you've got any evidence of Evans. So if you've got Evans syndrome and you've got a low platelet count, don't use it. But if your platelet count is normal, then generally, yeah, IMHA cases should get clopidogrel. I think we're actually at roundup time. So we've covered all things Cushing's disease today, and we hope you found this really useful. And fingers crossed, we've been able to add some new little nuggets you can add to help your clinical management of these cases.
Yep. Hopefully you enjoyed it. I certainly enjoyed reading up about it. I was super nerd. I loved it. Anyway, please get in contact with any comments or suggestions you have for us and topics you'd like us to cover next. That really does feed into exactly what we end up doing on the show. So contact us via our website, the WhatsApp number, or just via our social channels.
Yeah. Thanks again for listening to the Chatty Vets podcast. And we look forward to seeing you next Sunday for our next 2-week takedown episode, where we'll be covering everything from medications to reduce regurgitation in BOAS patients, bleeding bitch phase, and we also have another very special guest on the show.
Yes, we do. Keep an eye on our socials next week and we will reveal it then. Until then, it's bye from me.
And bye from me. Take care.
This podcast is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it is publicly accessible, it is not intended as advice for pet owners.
The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis.
Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.